Friends, so today's video lecture is on intravenous fluids in the critical care, and I've already posted around 13 videos related to critical care and general medicine. So this is another video, and I hope you will find it useful both for your practice and for the students for the exams. So you may be aware of my earlier tutorial, some of you. I am Dr. Tapesh Bansal. I'm an intensivist and a physician in Gurgaon, Delhi. And what are we going to learn in this session? We're going to learn about the different kinds of fluids, crystalloids, colloids, the different composition, their distribution, about albumin, the types of shock, how to identify shock, the different types of shock, and certain parameters used in fluid resuscitation, especially relating to septic shock, and how to manage fluids in septic shock, what is the ROSE acronym, and a few other things. So let us get started. Just to tell you about our evolution and the importance of water and saline. Life started as a unicellular organism in water. 75% of the earth is water, and millions of years ago the first form of life was a unicellular organism bathed in saline. Now even today we are multicellular organisms who have evolved over these years and are bathed in saline, right? The intercellular compartment has water and electrolytes bathed in interstitial fluid, which is saline, and we have sodium and water in our intravascular compartment. So we have a lot of saline in our body, and we are multicellular organisms evolved from unicellular organisms who are bathed in saline. So please remember that it is very easy to give fluids, but it is more important to realize that the question that we should be asking ourselves is, can we remove fluids in the ICU rather than can we give fluids? Giving fluids is very easy, but removing fluids is more difficult and actually more important. So the history of intravenous fluid starts from 1832 when this physician Thomas Latte gave IV normal saline for the first time in a cholera patient. And as you can read here, as the saline was started, drop by drop, life returned to this patient of cholera. And now we have 200 years of almost 200 years of IV fluids since that year in 1832. And what have we learned and what have we evolved to? Let us try and understand. So we have crystalloids and colloids. The definition is there in front of you. You can go through it. The essential difference is that colloids don't readily pass through the capillaries, while crystalloids pass much more easily. Colloids are much larger molecules. And here is a picture showing you the same. And crystalloids are passing easily through this membrane here. But this membrane is actually small pores in the capillaries, and much less of colloid passes through. Now, which fluids are to be used is a key question. We have so many fluids. We have normal saline, which is actually abnormal saline, and then we have balanced fluids. So as we move forward, we shall try and understand what is normal and what is abnormal in saline. Now, saline was called normal because many years ago it was seen that when you put RBCs in saline, they don't hemolyze. So the solution was thought to be physiologically normal. But as we know, it contains 154 milliequivalents of sodium and 154 milliequivalents of chloride, giving it an osmolarity of 308, which is more than the osmolarity of your blood, which is 280 to 295. So it is hyperosmolar. One. Second, the sodium content is high, the chloride content is very high, right? So it is not really normal, it is abnormal. And then we have balanced fluids, which are the closest that we have to your plasma or your blood. And plasma light is an example. So here I try to show you the different types of fluids, and you can look at plasma, the composition of plasma, and then we have normal saline, which I have just discussed. And if you see here, the pH is 5.7. Now where does this pH 5.7 come from? This comes from the formulation. Sodium chloride as such is not acidic, but when you make it, in the process of making it, because of exposure to carbon dioxide and exposure to the container, the plastic bottles, the glass bottles, whatever you are making it in, it leads to an acidic pH. So this is sodium chloride, and you can see chloride is very high. We shall discuss this as we move on. Then we have Ringer's lactate, which has an osmolarity of 273, slightly hypoosmolar, and chloride and sodium are much better here as compared to normal saline. And lactate is added to balance the positive and the negative charges in the solution. And then we have this plasma light, which we call balanced solution, and you can see why it is called balanced solution. Its osmolarity, the sodium chloride content is physiologically normal. Some people like to call Ringer lactate also as a balanced solution. So what are balanced solutions? I think you have understood what is meant by balanced solutions. This is to show you the acidity caused by infusion of isotonic saline. 5 liters of saline was infused over 2-3 hours, and you can see the drop in pH. And when you give Ringer's lactate, the pH remains same. Now, if the lactate is high, should we give Ringer's lactate? The question is, the answer is yes and no. If the liver function is impaired, then you should not give Ringer's lactate, because the clearance of lactate is by the liver. So the liver is not functioning properly, the lactate is just going to go on rising. One. Secondly, if the lactate is extremely high and you want to see lactate clearance, then again large infusions of Ringer lactate are going to impair your interpretation of lactate kinetics. So here again it would not be wise to give too much Ringer lactate, but otherwise you can give some Ringer lactate in a patient of shock. There is no problem with that. Here I've tried to show you the distribution of the different types of fluid, 5% dextrose, saline and albumin. When you infuse it, the distribution in different compartments. So you see 1 liter of 5% dextrose, only 100 ml remains inside, and for saline 275 remains inside. But you also see there is 825 in the interstitium, and if you add 275 to 825, it is more than 1 liter. Right? So how does that happen? If you ever read this, you may have wondered. I do not know whether you know the answer to this or whether you are aware of this. The answer to this here lies in osmolarity. The intercellular space, the interstitium and the intercellular compartment have the same osmolarity. That is a key concept. The osmolarity cannot be different. Otherwise, the cells will lyse or they will burst, depending on a hyperosmolar or hypoosmolar environment. So the osmolarity has to remain the same. Now, when you give saline, which is hyperosmolar, it moves out, like I've just showed you. It moves out because there is semi-permeable membrane in the capillaries, which has pores, which allows movement across the capillaries into the interstitium. So this fluid movement into the interstitium creates a hyperosmolar environment in the interstitium. This hyperosmolar environment relative to the cells makes movement of water from the cells out into the interstitium possible, thereby bringing the intracellular compartment in equilibrium with the interstitium in terms of its osmolarity. You may wonder why sodium does not move from the interstitium into the intercellular compartment and make the osmolarity equal. That is because sodium cannot move from the interstitium to the cells. There is a sodium potassium pump at the cell membrane, and this pumps out sodium and pumps in potassium. So only water is freely able to move across cell membranes. So that is the answer here. Then albumin, again you can see more of albumin remains inside while some moves outside. So this is about distribution of different fluids, the two common fluids, saline and 5% dextrose, and similarly you can extrapolate the distribution across the different compartments to other kinds of fluid like dN/2, dN/4 and so on, DNS and so on and so forth. Now I was talking about movement of fluid across the capillaries. So on top there is a capillary and there is endothelial cell, and the hair-like structure which you see in the magnification is actually called the endothelial glycocalyx. It is composed of basically a lot of molecules which have carbohydrate as their backbone, like glycosaminoglycans, proteoglycans, and this glycocalyx is very important in determining the permeability of the semi-permeable capillary membrane. And in sepsis, in SIRS and in other conditions, it gets damaged, as you can see in the bottom picture, and leads to a lot of leakage of fluid. That is why in sepsis there is so much leakage of fluid from the capillaries, that is the intravascular space, to the extravascular space. Now, just to again explain this fluid movement across various compartments, we start giving some fluid into the blood. Blood comprises 5% of the total fluid that you have. Extracellular space is 15% and intracellular space is 40%. Total fluid is 60% of your body weight. Now you have given saline to the intravascular compartment, that is you have infused into the blood, and some of it moves into the extracellular space, and thereby there is equilibrization between the extracellular space and the intracellular space, with fluid moving out from the intracellular space to the extracellular space to some extent, like I just told you in the last couple of slides. This is for normal saline. Now what happens with 5% dextrose? It's the other way around. In 5% dextrose, the glucose gets used by the cells. So all you have is free water. So when you give free water, it goes from the blood into the extracellular space, lowering the osmolarity, and thereby water moves from the extracellular space into the intracellular space to make the osmolarity same. So 5% dextrose distributes equally across blood, extracellular space and intracellular space. That is the difference between saline and 5% dextrose. And very little of 5% dextrose stays in the blood. That is why it is not good for resuscitation. Now what happens to the 500 ml of ringal lactate or normal saline you give over 15 minutes bolus? So you can see in green arrows, it actually finishes off in 6 hours. Within 6 hours it goes away from the circulation. Most of it has moved out into the extravascular space, and some of it gets filtered across the glomeruli and is passed out as urine. So that is the total time your ringal lactate or normal saline stays in your circulation, and the leak which I told you about is more than it moves out faster. Now, can you use 5% dextrose or DNS in a patient with shock? Now the problem here is that 5% dextrose is not a good fit for resuscitation, like I told you, because only 100 ml remains within the circulation. And for DNS, the problem is that again you are giving 5% dextrose. In DNS there is glucose, and glucose is not metabolized in these patients of shock because of bioenergetic failure. So you don't want to give DNS also in a patient with shock. need water in our bodies. We need water for two purposes. One is to maintain the circulation, and the second is for cellular metabolism. Now, the blood pressure drops to 90 by 60 from a blood pressure of 139 to 174. Let us get into some clinical medicine after having discussed the physiology. This is a common scenario in the ICUs, and what have we to do now? So the patient is in shock, as is obvious, and this is the distribution of different types of shock that we have. Obstructive shock can be either cardiac tamponade or can be because of acute cor pulmonale, and then we have 4% non-septic distributive shock, which is actually anaphylactic shock or neurogenic shock or even shock due to hypoadrenalism. And one type of shock which is not covered in most of the classifications is endocrine shock. That is because of hypothyroidism or hypopituitarism, and there is another class which is called a mixed class of shock. For example, a patient sometimes can have two types of shock. He can be having both septic and cardiogenic shock, for example. So we have to see what kind of a shock the patient is in clinically when we first see the patient. One of the ways to make out is to just feel the extremities, and if the extremities are cold and clammy and the patient has some cardiac risk factors, it is likely to be cardiogenic shock. Sometimes there may be no risk factor. Young patients also get MI and cardiogenic shock. So the key here is cold clammy extremities with a low pulse volume. The pulse volume or the pulse pressure, that is the difference between the systolic and diastolic, is always low in cardiogenic shock. And because of intense sympathetic stimulation, there is sweating and cold clammy extremities. While in septic shock, you don't get cold clammy extremities, and the pulse pressure or the pulse volume will be a little better. And if in any shock you get a diastolic pressure of 50, it means there is intense vasoplegia or loss of vasomotor tone, which means there is a distributive shock, and distributive shock in 95% of the cases is septic shock. And other than that, you can look at the history. A septic shock patient will have some degree of fever, often maybe having a focus of infection. So this is how you differentiate septic shock from cardiogenic shock. And the other types of distributive shock like neurogenic or anaphylactic again will have a low diastolic pressure, and pulse volume will be a little better, and there will be intake of some kind of a drug or maybe even prawns. Seafood can also cause anaphylactic shock, and neurogenic shock can occur in trauma to the spinal cord, that is spinal cord injury, or can occur with viral infections causing autonomic neuropathy, because the autonomic nerves control the vasomotor tone. And hypoadrenalism can occur if there is sudden withdrawal of steroids. For example, a patient is on chronic steroids and he falls sick, stops taking steroids for the last 4 or 5 days, not taken steroids, he will go into hypotension. Or you may have just a patient presenting with Addisonian crisis. There the history will be of a chronic duration, and you should know the symptoms of Addison's disease. Obstructive shock will be cardiac tamponade or pulmonary embolism, and that again will have some degree of features of cardiogenic shock, but not so much like left ventricular cardiogenic shock. And there are clinical features suggestive of pulmonary embolism and cardiac tamponade. Cardiac tamponade patient will have pulses, paradoxes often, and because of the pericardial effusion, heart sounds will be muffled and JV will be raised. And acute cor pulmonale, if it's occurring because of pulmonary embolism, will have significant hypoxia with a clear X-ray and sudden onset of breathlessness. And hypovolemic shock will be evident from fluid losses in the history. Rarely you may have concealed GI hemorrhage, but GI hemorrhage would not just occur in any patient. Either there will be history of NSAID intake or there would be chronic liver disease. Sometimes you may have surreptitious GI bleed with patient not having passed melena yet or had hematemesis. There, of course, you will have to mm, be more vigilant and kind of have sharp clinical acumen in making out that he has concealed GI hemorrhage. So this is how you approach clinically a shock patient and try to make out what kind of shock he has. So echo is a useful tool in shock, and you can see in distributive shock you'll have normal cardiac chambers with normal EF. In hypovolemic shock, small chambers and high or normal contractility, and in cardiogenic shock, large ventricles and poor contractility, while in obstructive shock you'll have in tamponade effusion, small ventricles and dilated IVC. In pulmonary embolism or pneumothorax, dilated right ventricle and small left ventricle. So this is septic shock, this is obstructive shock, this is cardiogenic shock, and this is hypovolemic shock. Can you make out the difference here? Why is it septic? Why is that obstructive? Why is that cardiogenic? Why is that hypovolemic? Except hypovolemic, all other are four C views, and you can see here in septic shock the LV is normal, and in obstructive shock that is a septic shock. In obstructive shock the RV is dilated. Wherever the RV is equal to LV or the RV is bigger than the LV, it means that your RV is dilated. And here the RV is dilated, and here you have a massively dilated LV, cardiogenic shock, and there you have small ventricles with LV walls almost kissing each other as in hypovolemic shock. So echo is a useful tool, and all intensivists should have a basic knowledge and operating skills to do an echo. So what would be your approach now? Fluids, obviously, except in cardiogenic shock, and in certain cases of cardiogenic shock, even those cases you may sometimes be helped with fluids, but we will not discuss that. So you want to give fluids, how much and which one? So how do we decide how much fluids to give? So there are many ways which have been described, and I shall try and focus on three of these, that is PLRT, which has the best accuracy and pulse pressure variation, and a little bit about CVP. Before we come to that, what is a fluid bolus or a fluid challenge? So 500 ml given fast, and then you see the response after that, and it should be an increase of a cardiac output of at least 10 to 15%. How do you make out the increase in cardiac output? It depends entirely on the kind of devices that you have. But ideally, to see the response is imperative, because otherwise you won't know whether the patient is fluid responsive or not. So 500 ml is the general definition, but to be very precise, minimum is 4 ml per kg normal saline, because different sources give different definitions of fluid challenge. That is what is a fluid challenge. There is something known as a mini fluid challenge, which is more of a theoretical concept, because here you have to demonstrate a rise of cardiac output of 5%, which is actually very difficult. So this is the approach to a patient who actually has supposedly septic shock, and if you look at the flow chart here, we can see here that is there hypovolemia, which is obvious, there is obvious fluid losses, and the patient is in initial phase of septic shock. So if yes, then you give your bolus of fluid, and it should be 10 ml per kg approximately, unless there are obvious fluid losses or the patient has abdominal sepsis where the leakage is much more. So something like 1 liter in most of the cases, and not 30 ml per kg, which amounts to 2 liters, is the initial bolus that you should be giving, unless, like I just told you, you think there are more fluid losses. Now, this is if there are obvious fluid losses or there's initial phase of septic shock. Now, initial phase of septic shock means whether he has already received fluids or not. Sometimes patients are shifted from other hospitals and they have received the fluids already. So then this volume expansion is not performed, and you have to follow this pathway here. You have to check for preload responsiveness, and you have to see whether the patient is on the ventilator, whether he is an AF or any other kind of arrhythmias, and if he has ARDS or not, because ARDS means there is poor lung compliance, which has significance as we shall move on here. So just to tell you about the fluids, patient with septic shock, infuse around 10 ml per kg crystalloids. Please note crystalloids, not colloids, within the first hour, that is fast, and increase the infusion, that is give more fluids if there is evident fluid losses, abdominal origin of sepsis because there are more fluid losses, or if there is high fever. So this is just to carry on from our previous pathway. Now we have talked about ventilation, whether the patient is spontaneously breathing, arrhythmias and ARDS. So if it is no, that means if the patient has no arrhythmias and is on the ventilator and he has a reasonable lung compliance, then you can use pulse pressure variation, and you can use your IVC also, respiratory variation, and passive leg raising can be done in both the conditions. Passive leg raising has only two real contraindications. One is raised ICT and the other is abdominal compartment syndrome. Abdominal compartment syndrome is not a contraindication as such, but you can get a false negative in abdominal compartment syndrome and it may be difficult to perform in these patients. So this is how you have to approach. You have to check for fluid responsiveness after your initial bolus with one of these techniques, and pulse pressure is possible only in actually 20% of the patient at any time in the ICU where you want to check fluid responsiveness because it has many limitations. So after you have checked for fluid responsiveness, is the patient responsive? If he is, then consider volume expansion. Depending on the risk of fluid overload, this has to be individualized, and do not consider volume expansion if the patient is not responsive. So pulse pressure variation is actually taken as 13% variation, and I will just show you the picture on this. And it has been also seen that after your initial bolusing of fluid, only 50% of the patients actually are fluid responsive. So much fluid is not required, and this has been realized over the last few years. So now we shall talk about pulse pressure variation and or pulse, PLRT. So how to perform, I'm sorry, that is actually PLRT, not PPV. PLRT without automated bed and cardiac output monitor. So ideally, PLRT should be done with your automated bed and a monitor which can tell you the cardiac output. So this is fine if your ICU has this technology, but in many ICUs a proper automated bed is not available, and often they don't have any device to check the cardiac output. So how do we do in these patients, and can we do in these patients this test of passive leg raising? That is the most accurate test as of now. And one of the beautiful things is that you don't give any fluids here. You just auto transfuse the blood by changing the position, as you can see here in the picture, and blood goes from the legs and the abdomen up into the heart, and it's like a fluid challenge, and then you see the change in cardiac output at the end of 1 minute, and it should be within the next minute after performing the maneuver, because after that you do not see the change in cardiac output, and it should be an increase of at least 10%. So that is how you're supposed to do it, and explain the procedure carefully. Do not cause pain. That is the most important thing. You do not cause pain, and gently bring the patient to this position as shown, and see the increase in BP at the end of 1 minute. At the end of 1 minute is very important, because after that the cardiac output normalizes. And any tachycardia nullifies the test, because that means the patient is having sympathetic stimulation. So tachycardia should not be there. And if you are actually doing with the automated bed, then bring the patient back to the position he was in initially here, right? First he is like this, then you do the test here, see the cardiac output increase, and then you again bring him back to the original position and see the drop in cardiac output. But this may not be possible without an automated bed, because you will be causing pain. So this is how you do it. When you don't have an automated bed and don't have a cardiac output monitor, you just see the increase in blood pressure. And it has been seen that approximately 80% will have an increase in blood pressure out of 100 patients who increase their cardiac output. That means around 20% will be false negative if you use blood pressure as your target and not cardiac output. So it is worthwhile to do it, and it is an easy test, and it is the most accurate test as of now, especially if you have an automated bed and a device which can tell you the increase in cardiac output. Now, looking at pulse pressure variation, you can see what is pulse pressure variation, and there is a formula which tells you how to calculate pulse pressure variation. It is given everywhere, you can just look it up, and sometimes the monitor itself tells you the ppv value, and it should be 10 to 13%. Between 10 and 13% is a gray zone, and the variation occurs between inspiration and expiration. As you can see, this is a patient who is on the ventilator on 8 ml per kg, and with no spontaneous respiration, and he is having no arrhythmias. These are the three criteria for pulse pressure variation. He should be on the ventilator, paralyzed, with no spontaneous breathing, and 8 ml per kg should be the tidal volume, and there should be no arrhythmias. So if these criteria are met, you can check for pulse pressure variation, and if it's more than 13%, that means he is fluid responsive, and you can give the fluids. The difference in pulse pressure and inspiration and expiration actually occurs because of interaction between the heart and the variation in the thoracic pressures that occurs with your respiration. In a normal individual also, when you breathe in and out, there is variation in the intrathoracic pressure, which is transmitted to the ventricles of the heart, which results in phasic changes in stroke volume and inspiration and expiration. And this is what you use in your pulse pressure variation. This is the principle. And these are the conditions where you get false positive and false negative. And in ARDS patients, especially severe ARDS patients, it is difficult to do it because of low lung compliance. And again, in increased intra-abdominal pressure, it is false positive if you take it at 13%, and it's recommended that you use 20% as a cutoff in patients of increased intra-abdominal pressure. And the respiratory rate is also important. As you can see, the heart rate and the respiratory rate ratio is important. And again, in right heart failure, it is very difficult to interpret it. It is false positive, and you cannot really use it in right heart failure. And this patient on ventilator is normally getting 6 ml per kg, because those are the recommendations, especially in ARDS. So you can perform a tidal volume challenge, increasing your tidal volume from 6 ml to 8 ml per kg for a minute, and then see the change in your pulse pressure variation or your stroke volume variation, which should increase by approximately 3 to 4%. And if that is the case, that means your patient is responsive to fluids, and that is called the tidal volume challenge, because normally the patient knows 6 ml and you need 8 ml per kg to do this test. So you give this 1 minute challenge, and the pressure will go up. That is why you cannot use 8 ml per kg consistently. You have to keep the tidal volume at 6 ml per kg to have ventilation in ARDS patients. So for a minute you can increase to 8 ml per kg, and then see the increase in the PPV or SVV, and if there is an increase of around 3 to 4%, that means the patient is fluid responsive. So CVP has been seen to be the most widely used parameter in the FINEST study, which is a worldwide study for ICUs a few years back. What is its role today? It has become very controversial, and many of you must have heard that CVP is not a reliable tool, but that is not so. It has its own uses, and here I shall try to help you with CVP. So when you give a fluid bolus of 500 ml, if the CVP does not rise, that means that the patient is fluid responsive. If it rises and falls, that means you are at an intermediate state of fluid. And if it rises and stays high, it means that the patient is not responsive, his ventricles are full, and he should not be given fluids. So that is about CVP, one of the ways you can use CVP. And the only problem here is you will be giving 500 ml to the patient, and if he is here, then you can actually cause some seepage of fluid into the lungs, and if it is ARDS, it won't be good. But this is a way that in which CVP can be used, and extreme values of CVP are always valid. If you have a value of 0, -1 or 1, then it means he's dehydrated. And just similarly, if he has a CVP of 13, 14 means he's overloaded, the right ventricle is overloaded. And in patients of increased intra-abdominal pressure, it is said that half of the IAP can be added to your CVP. So CVP cannot be just thrown away and say it is not relevant. It has its relevance, and this is how you can use the CVP. Now, understanding the physiology of septic shock. Again, we just talk about septic shock and fluid responsiveness, and why we do not get a good blood pressure despite using an adequate amount of fluids, and what happens to these fluids when you give these fluids. So as you know, there is gross vasodilatation both in the arteries and the veins, and you start giving fluids to this patient of septic shock, and as you give fluids, the heart becomes full, right? At a stage will come when the heart will become full, and when the heart becomes full, it cannot pump out any more fluid, and your aorta and the peripheral arteries are all dilated, and because they are dilated, you will have a low blood pressure despite filling up your heart with maximum amount of fluid, and it is at this stage when you will not get any fluid responsiveness, as shown by the Frank-Starling curve. That is the Frank-Starling curve, and till that point that is marked, you will get fluid responsiveness. Beyond that, your heart is full with fluids. The patient is not responsive to your dynamic parameters of fluid responsiveness, and pushing in more fluids will actually worsen the condition. So that is why you do not get an optimization of your map despite giving fluids, the patient becoming fluid unresponsive, and that is because of your extreme vasodilatation, and there only your vasoconstrictors will help. And if the vasoconstrictors also are unable to constrict the vessels, your arteries, then your blood pressure will not come up. Now we talk about all kinds of electrolytes, but we don't talk about chloride. So a few slides on chloride, and we go back to normal saline. If you remember, I told you it's 154 milliequivalents of chloride in 1 liter of normal saline, and if you push in too much normal saline, your chloride levels go up. And it has been seen in hyperchloremia that there is a risk of increased AKI, and chloride should be kept less than 110 in the patients in the ICU to avoid this. And that is why normal saline is not as advocated as a fluid of large volume resuscitation. And the mechanism for hyperchloremia induced renal failure is that when the chloride goes beyond 110, it actually causes AKI, because it gets filtered in a large amount across the glomeruli and reaches the macula densa, and signals from the macula densa cause afferent arteriolar constriction, leading to decreased GFR. And this was shown very clearly in the SMART trial. Before the SMART trial, there was conflicting evidence, but there were signals that hyperchloremia is injurious and leads to renal injury. And here you can see very clearly that the forest plot actually favors balanced crystalloids. and saline worse outcome. And even in sepsis patients, here you can see the outcome is better with your balanced crystalloids. And it has been seen that not only hyperchloremia but even hypochloremia increases the risk of mortality. This is a U-shaped curve, and here in this light blue is the normal chloride levels, beyond that is the hyperchloremia, and here in purple is hypochloremia. So even hypochloremia has been shown to actually lead to increased mortality, and this curve depicts mortality, and it's lowest in the normal chloride range. So try to keep chloride in the normal range, especially avoid hyperchloremia. Not so much is known about hypochloremia, and hyperchloremia has been shown to be associated with hemodynamic instability and even coagulopathy. So hyperchloremia comes from infusion of chloride-rich fluids, from diarrhea, hypovolemia, because there's intense absorption of sodium and chloride, and decreased bicarbonate. And hypochloremia, you can see the causes here. Please remember that chloride is linked to sodium and bicarbonate. And the equation here is the equation for anion gap actually. This shows the balance of positively charged ions and negatively charged ions, and you can see that if sodium goes up, chloride will go up. That is to maintain the electrical balance. Similarly, if the bicarbonate decreases, your chloride will go up. So chloride actually follows bicarbonate and sodium closely in the body, and if you are trying to find out the cause of increased chloride or decreased chloride, have a look at the sodium and the bicarbonate. Now, osmolarity of DNS is 560, which is almost twice the normal osmolarity of the extracellular fluid, and glucose utilization is impaired in critically ill, and large volume of D5 can result in cellular dehydration as will move out from the cells. So this should be clear to everybody, and that is why it is not a good fluid, like I told you earlier. Now, which fluid is best for resuscitation? I've already told you about DNS and 5% dextrose. So plasmolite is the best fluid because it is the balanced fluid, and NS and RL can be used in small amounts. Albumin is not to be used as a volume expander for resuscitation, and blood for hemorrhagic shock is fine. There's no problem with that. That is the fluid of choice. Now, which fluids for raised ICT and encephalopathy? Please give only normal saline or isotonic saline. If you use 5% dextrose, then you are going to cause cerebral edema and you raise the ICT. And it has been shown clearly that albumin increases mortality in traumatic brain injury and is contraindicated. And that is probably because albumin also leaks out from the intravascular to the extravascular space and can increase the oncotic pressure and the cerebral edema. So use isotonic or hypotonic saline, that is fine in raised ICT patients. You often use hypotonic saline like in hepatic encephalopathy or raised ICT patients. Then what to do with colloids? The only colloid recommended now is hydroxyethyl starch, and it cannot be given in patients of sepsis or who are predisposed to renal failure because it causes AKI, RRT, and there's an increased risk of bleeding with these patients. Whether small amounts can be used in certain situations where you don't have these factors, these clinical conditions, is not clear. There is no evidence for or against in these situations, and a bottle of colloid, that is HES, is more costly than just normal saline or ringal lactate. And how it causes AKI is that it is hyperoncotic to some extent, thereby decreasing GFR, and also because a lot of it gets metabolized in the blood, and when it goes to the kidneys, it causes inflammation and damage to the renal parenchyma. Then albumin, certain facts about albumin here, that 10 grams is produced by the liver daily and metabolized. Low levels in ICU due to multiple reasons, though the production is actually increased. It stays in circulation for 18 hours. Please note that. And it is not filtered across the glomeruli. And if the capillaries are excessively leaky, like in sepsis, then it moves out much faster than 18 hours. And it helps in sepsis because of its other properties. not because it's a volume expander, but because it has pleiotropic action. And I will just show you these actions. And this is very weak evidence, but some albumin may be used early in sepsis if you want to use it, and can be used for de-resuscitation along with furosemide. And it's a costly molecule, and that should be borne in mind, especially in resource limited countries, and it can lead to infections and anaphylaxis. Now, which albumin, 20% or 5%? So 5% actually comes in 250 ml, while 20% comes in 100 ml. So when you give 20%, you are giving a lot of albumin fast. Thereby, if you give it 20% over 10-15 minutes, you suddenly draw water from the extravascular into the intravascular space and can throw the patient into pulmonary edema even. So you should not give it as a bolus. Please remember that it should be given slowly, and the rate of albumin administration becomes more important here. So 20% is in 100 ml and 5% is in 250 ml. And if you give 20% fast, you'll be drawing in a lot of fluid and cause even pulmonary edema at times if cardiac patients. That has to be borne in mind. So these are the pleiotropic effects of albumin, and you can see it has multiple actions, and it is known to even counter nitric oxide in sepsis patients. So it can be used. There's weak evidence, and these were the landmark trials for albumin as fluid resuscitation. And prior to the SAFE study, it was seen that albumin is harmful, but it clearly showed that there is no mortality benefit and no harm, more importantly, if you use albumin in the intensive care unit. Whether you use albumin or saline, it was the same for resuscitation. And the ALBUMIN study actually targeted 3 gram per liter of albumin in patients of severe sepsis or septic shock, and small benefits were seen in certain endpoints. And this is now thought to be because of its pleiotropic effects, as I just told you, and not because of volume expansion. So when should I give albumin in my patients? So these are mainly liver patients where you should give, where there is clear-cut evidence, and maybe a little amount can be given in septic shock as per sepsis 3 guidelines. Blood is good for resuscitation if there is hemorrhage, but please be aware of fluid overload, and 7 grams is sufficient generally in most patients, even in surgery patients. And this is a reality trial conducted this year, and it was found even in MI patients a target of 7 to 8 had no increased mortality. Then we come to the ROSE trial. So here in the ROSE acronym, R stands for resuscitation, O for optimization, and S for stabilization, and E for evacuation. So the thing here is, initially you resuscitate, and then after that you check for fluid responsiveness after your initial bolus and optimize the fluids, and then stabilization with your maintenance fluids. And finally you have your evacuation or de-resuscitation, and you can check for fluid responsiveness when you're going to de-resuscitate. So de-resuscitation is an important aspect of managing septic shock. This ROSE acronym is actually mainly for septic shock. As is evident, you give the fluids first as your bolus, and then some maintenance, and then finally, as the patient's blood pressure stabilizes, you try and remove the fluid, because removal of fluid is very important, and that is E for evacuation. So you can check for fluid evacuation by again checking for fluid responsiveness. If he is not fluid responsive, that can help you in deciding that he is overloaded, and you can now remove the fluids, because you do not want to remove the fluids if he is still hypovolemic, because you will cause further hypotension. So this is an important concept of first resuscitation, then optimization, and then final evacuation. So that was about fluids, resuscitation, septic shock, the different parameters that we have, and one has to combine technology with clinical medicine, clinical acumen. Neither is sufficient alone, but combining together gives you the best results. So maintenance fluids actually are not needed if the patient is taking orally and if he's on enteral feeds or on TPN. But if he's on neither of these, then you should give some maintenance fluids. And there is no real fixed formula for maintenance fluids. You have to cover the urine output and what kind of a balance he is in, and you have to look at the electrolytes, and you have to cover for the losses also, the insensible losses and any losses from the drains, etc., your NG tube which you may have put. And it has been seen that these maintenance fluids are a very important component of the total fluid balance that the patient has. And in orange and red is actually the resuscitation fluid, and the rest is the maintenance fluid and the creep fluid which sets in to the patient's fluid balance at 1 week. This shows you the chart of fluid balance at 1 week. So a significant amount of this is maintenance fluid and the other fluid that goes into the patient's body. And at 72 hours after the patient has stabilized, you should be de-resuscitating the patient, and you can actually give some Lasix with albumin if you want, or you can even use dialysis if there's a renal shutdown. This is evidence-based guideline to use dialysis because de-resuscitation is very important. And a patient who has more than 10% of increase in his body weight, that is due to fluid balance, positive fluid balance, is supposed to be in positive fluid balance, which is harmful to the patient. Even a lesser amount is harmful, but anything which is more than 10% of the initial admission is a negative prognostic factor. So worsening organ failure due to excess fluids, and you can see in the different organs what all it can do, and even in surgical patients it can cause problems. And most importantly, in the gut, if there is edema, there can be secondary hit. There can be secondary sepsis. The gut is the commonest cause of secondary sepsis, and you do not want to lose a patient due to secondary sepsis, one who you have treated successfully from his primary sepsis. And there is a term called GIPS, that is the Global Inflammatory Permeability Syndrome. So what normally happens is, as your sepsis resolves, patient often has a spontaneous mobilization of fluid from the extravascular into the intravascular space, and this moves out into your kidneys, and your urine output increases. And you may have seen this sometimes, that as the patient is improving on day 3, day 4, the urine output suddenly improves, and you may have wondered why this happens. So this happens because of this reason, that there is spontaneous mobilization of all the fluid that you have given into the intravascular compartment and improved GFR. But sometimes this does not happen. The patient does not improve, and there is ongoing fluid accumulation and the need for giving fluid, and this combined with a new onset organ failure is called global inflammatory permeability syndrome. And in the post-operative state, there can be bowel dysfunction, ileus, anastomosis leak, and delayed weaning, and using low urine output in these patients as a marker of giving fluids is wrong actually, which is a common practice in the surgical ICUs, that you look at the urine output in the post-operative state and give urine, because there is an entity called post-operative SIRS. When you dissect the patient, when you dissect the tissues, you cause inflammation in the tissues, and this is akin to systemic inflammatory response syndrome. And depending on the kind of surgery you are doing, you can even have hypotension post-operatively purely because of SIRS, or you may have single organ involvement, and often the kidney is affected because of surgery, and the urine output is low not because there's a hypovolemia, but because there's an element of SIRS in kidney. When the kidney suffers in sepsis, it is because of two reasons. Either there is hypotension, or sometimes there is no hypotension, but because of the cytokines, the kidney becomes dysfunctional. So a similar condition can be seen sometimes in the kidney in the post-operative state, and here using your urine output will be disastrous. You keep pushing in fluid while the kidney is actually dysfunctional, and thereby it is not a good marker of your fluid responsiveness. So urine output should not be used, and objective parameters should be used to guide fluid therapy in the post-operative state. So I hope you were able to get this message that excess fluids increase mortality and have to be removed after initial resuscitation. Please give it carefully. Any fluid that we give in excess is like a small dose of poison. This is an example here of fluid creep. So polymyxin B is actually given in 1 liter or minimal 500 ml, and linezolid also 600 mg comes in 300 ml. So if you are giving polymyxin B and linezolid, you are giving 1.5 liters of fluid to the patient, and if the sister is not charting this will be going into the body without any evidence on the charting, and this is what is called fluid creep. Fluid which goes in with other things without administration, or even if it is charted, then you don't realize that the patient is getting these fluids. So this is what is called fluid creep, fluid other than your IV fluids which you are giving as maintenance fluid. And this is another example I just want to show you. This happens sometimes in resource limited countries where the quality of products is not up to the mark. Sometimes there are manufacturing lacunae, and there can be poor formulation of intravenous fluids which can themselves lead to sepsis, and sometimes albumin can cause anaphylaxis, and infection can be transmitted by albumin also. So these things also one should be aware of. And finally, coming to the last few slides, you can just have a look here. There's nothing much for me to say, and positive fluid balance I've already defined for you. And please don't use 5% albumin as a fluid expander. It is not a very good fluid expander. Little amount may be given in certain situations, and avoid hyperchloremia. And for fluid deficit with alkalosis, normal saline is the recommended fluid, and oliguria is to be taken with a pinch of salt as a marker of fluid resuscitation. And as far as colloids use is concerned, probably in situations where there is no renal failure and no sepsis, a small amount of hydroxyethyl starch can be used. And I think we are coming to the end of our tutorial. And for those of you who like paintings, this is a very famous painting by the Japanese painter, and this is showing you the fluid status in the patient. There is a lot of turbulence as far as fluid is concerned, and we have to make sure our boat sails through smoothly. So thank you for listening to this tutorial so patiently. I hope you found it useful. If there are any questions, you may send them to me. Thank you so much.